Good evening, everybody, and welcome to this special Gairdner session. I'm Janet Rossant, and I'm president of the Gairdner Foundation, and I'm delighted to be here again at the CUGH conference to moderate this session featuring the 2021 John Dirks Canada Gairdner Global Health Award. It's been great to partner with Keith Martin and the team at CUGH to bring the Gairdner Awardees in person to CUGH over the years. And we hope to be back next year in person to do exactly that. Best known for the prestigious prizes we award to outstanding scientists around the world, the Gairdner Foundation is an icon in the Canadian and international scientific community. Our mission is to celebrate scientific excellence, to convene leaders, and inspire the next generation. The John Dirks Canada Gairdner Global Health Award is one of our awards that's given annually to recognize scientists who've made or are making important scientific contributions to health in the developing world. And it's rapidly become recognized as really the most prestigious international prize for global health research. The announcement of the 2022 Gairdner Awards takes place on April the 5th. You can tune in online via our website to get the news. I would like to invite each of you to consider nominating a global health scientific leader for the Gairdner Award. Nominations for the 2023 award will be open on April the 6th, and you can find the nomination guidelines on our website in English, French, Spanish, Portuguese, Arabic, and Chinese. The deadline for nominations is October the 1st, 2022. We're particularly seeking nominations from underrepresented groups and from those researchers who are based in low and middle income countries. So in 2021, the award went to Drs. Malik, Peiris, and Yi Guan from the University of Hong Kong for significantly contributing to understanding the emergence and options for control of newly emerging infectious disease outbreaks in Asia, notably zoonotic influenza and severe acute respiratory syndrome, or SARS. Together, they initiated seminal studies on the H1N1 avian flu outbreak and identified its transmission from live poultry markets. And when SARS emerged in 2003, Dr. Peiris led the team that identified the novel coronavirus that was the causative agent, and he developed the first test for the virus. Dr. Guan identified its zoonotic transmission in the wild animal markets in Guangdong, leading to the closure of those markets. Their ongoing work is, of course, highly relevant to today's COVID pandemic and provides many lessons to be learned, as we're going to hear from Dr. Peiris today. Dr. Guan is unable to be with us today, but I'm really delighted to welcome Dr. Peiris to the virtual stage to give his lecture. It'll be followed by a short Q&A period, so I encourage you to place any questions in the chat, and I will try to get through them. Dr. Peiris is director of the School of Public Health, the University of Hong Kong, chair in virology at the university, and holds several other key posts. His talk today is entitled COVID-19, a research response and lessons for future pandemic responses. Dr. Peiris.
Thank you very much, Janet, for that kind introduction, and I hope you can hear me well. I will share my screen now and into full screen. Yes, I hope you can see that well as well. Yes, I'm delighted and honored to be with you today at the Global Health Conference. And what I thought I'll do today is first to talk about our own small research group's response to the COVID-19 pandemic as it emerged, and then talk about lessons for future pandemic preparedness. Our early research response to the COVID-19 outbreak involved these four people here, as well as myself. So that is what I'll talk about in the first half of the talk. So as COVID-19 emerged, when we heard about this outbreak in Wuhan, clearly the first options for response, because we didn't have vaccines, antivirals, or any pharmaceutical measures, was the public health and social distancing measures and testing, contact tracing, and quarantine. Now, in order to understand and implement public health and social distancing measures, we really need to understand the modes of transmission, and then that determines what interventions work. So you will remember the issues about large droplet transmission, airborne transmission, indirect contact transmission, etc. So in the first week of January, when we heard that this was a SARS-like coronavirus, at that time we didn't have the sequence, we set out to develop pan-sarbecovirus. So that's that subgenus family of the SARS-1 and the related bat viruses. So we developed the RT-PCR assay to detect that group. And of course, we had the SARS-1 as a control, and we essentially had the assay up and running within a week. And of course, when the genome sequence came out, we could see that the assay really was well matching. And that was what we used in Hong Kong in the first weeks. And indeed, in the first few weeks and months, we had requests from over 170 laboratories in 77 countries because they were desperate to have some diagnostic tools at their disposal. And indeed, a number of countries made their first case diagnosis based on these assays. Then we come back to this issue of public health and social distancing measures. But modes of transmission of respiratory viruses are really a black box. And indeed, some years ago, we did realize this, and we applied for and got a program grant from Hong Kong, a 5-year grant, to look at the determinants of transmission. And this was focused on influenza virus at that time. So as part of those studies, we had set up studies looking at the airborne particles that come out of patients with respiratory infections. And this was done with my epidemiology colleague, Ben Cowling. Essentially breathing into this very cumbersome apparatus that you see. This was, as I say, before COVID-19. And patients with acute respiratory infection, we were targeting influenza, but some of these individuals turned out to have the seasonal endemic coronaviruses. And what we found really was that we could detect virus, and in fact, infectious virus as well, in the large droplet fraction, but also in the small airborne droplet fraction as well, so less than the 5 micrometer fraction. But more importantly, we had the same people wear surgical masks, and you can see that the surgical masks essentially reduce the release of infectious airborne particles, not only in the large droplet fraction, but also substantially in that fine so-called aerosol fraction. Now, of course, that is not likely to be perfect, but it clearly had an important effect. So the lesson was that surgical masks do reduce the escape of airborne particles from infected people. And then subsequently, as it became clear that pre-symptomatic individuals and even asymptomatic individuals may transmit, the role of surgical masks in the community on a mass scale became rational. Now, of course, as you know, this was quite controversial for quite a long time. And this comes to my point that we still, even at the end, well, we are not at the end, but at this stage of the COVID-19 pandemic, we still do not fully understand modes of transmission of respiratory pathogens, COVID-19, but influenza, rhinoviruses, RSV. We have a lot of dogma, but the science underlying it is not clear. So more recently, as you might have seen, there are now epidemiological studies that clearly show the effectiveness of face mask or respiratory use in indoor public settings. Another question in terms of transmission that we were interested in looking at is survival of infectious virus on surfaces. That is a determinant of indirect transmission or fomite transmission. And what you can see here is that SARS coronavirus 2 can survive, although there's a small drop here, but it can survive for days on smooth surfaces, such as stainless steel, on plastic tops, on glass, etc. Now, if you just compare that with influenza virus, and this was studies done previously by others, you can see that influenza virus is essentially gone in terms of infectivity within 10 hours or so. But SARS coronavirus 2 is very different. And indeed, more recently, we have looked at Omicron, the BA1 variant, and it is even more stable than the original Wuhan virus. Of course, stability on surfaces is not just enough. The virus also has to survive on your fingers, because your fingers will transfer the virus from surfaces to your mucous membranes. Although, of course, you can also aerosolize dried virus, infectious virus from surfaces as well. But a Japanese group in 2020 looked at this and showed, in fact, that SARS coronavirus 2 can survive, in fact, for longer than influenza survives on the skin. And so therefore, it is plausible that the indirect route of transmission can play a role. Having said that, up to now, the direct evidence for the importance of this route is still unclear. So I come back to this. I mean, we still have a lot to learn about the modes of transmission of respiratory viruses. And I think it definitely deserves more investment and attention, because it will be the next respiratory pandemic is the one that we need to prepare for while we are dealing with COVID-19. Another important question that we faced right at that in those first early weeks was the dynamics of transmissibility. Now, what you see here is the viral load characteristics that we saw with SARS-1 in 2003. So these are individual patients followed up over time, and you can see that in the first 4 or 5 days after onset, the viral load is relatively low, and this peaks at the end of the first week of illness, and then, of course, declines. And in parallel with that, transmissibility was maximal in the case of SARS after the first 4 or 5 weeks of onset of symptoms. So, and this was how the outbreak was contained, because once you begin to isolate patients in these first few days, you can break the chain of transmission in the community for SARS-1. So what was the situation with SARS-2? We were able to collaborate with our colleagues across in Guangdong, who were seeing cases by that time, and we could show that the pattern with COVID-19 was completely different. So you had peak viral load at the time of onset of symptoms, and indeed subsequently we were able to show even before the onset of symptoms. And so the viral load kinetics with COVID-19 looked more like influenza. So in that paper that we submitted at the end of January 2020, we basically said that the pattern of patients infected with SARS coronavirus 2 resembles that of patients with influenza, and that the strategies that we require strategies different to those required for the control of SARS coronavirus 1. And subsequently, our EPI colleagues working together with China CDC essentially established that about 40% of transmission was taking place before the onset of symptoms. And this has been now amply confirmed in many other studies as well. Experimental animal models are important when you deal with a novel emerging infectious disease. And my colleague Huiling Yen established the golden Syrian hamster as a good model for SARS coronavirus 2 very early on. So you can see the weight loss that you see in these hamsters that are infected with the virus. You can see the pathology in the lungs. And more recently, she has gone on to use this model to look at therapeutic options, monoclonal antibodies in terms of reducing disease, etc. But then she also observed in these very first experiments, saw this divergence between RT-PCR positivity and virus culture positivity. RT-PCR continued to be positive for quite a long time, but the virus culture, which is the marker of infectiousness, essentially dropped and disappeared by 6 days. And when she did contact transmission by putting naive hamsters in direct contact with these infected hamsters, at day 1 after infection, experimental infection, 3 out of 3 contact hamsters got infected. But by day 6, even though the PCR viral load was very high, there was no transmission. And this, of course, was a parallel question that we were facing in our hospital wards, where the question was, how quickly can we discharge these patients from hospital? And so we quickly looked at a cohort of a number of patients in our wards. And here you can see the crosses are the PCR viral load in these patients. And you can see some patients do have high viral load going on for more than a month, sometimes 2 months. But when we cultured these same specimens, we could see that virus isolation was only possible in the first 8 or 9 days after onset of clinical symptoms. So that led to a change in our hospital discharge policy, because at the early stages, patients were being kept in hospital until they became PCR negative, which can be many weeks. And sometimes patients are perfectly well, sometimes right through that time as well. So that changed the policy for discharge, both in Hong Kong, but then because there are other studies also supporting the same argument also at WHO. We always have been working at the One Health paradigm, working together with our animal health colleagues. So with that collaboration, we were able to see transmission of SARS coronavirus 2 from infected humans to pet dogs and to pet cats. And in fact, the transmission to dogs was the first reported case of transmission to any animal species during that COVID outbreak. Now, of course, as you know, there is spillback from humans to animals have been documented in over 29 species. And in some of these species, the virus has become enzootic. For example, in North American white-tailed deer and in minks, in mink farms, at least until the mink are culled in the case of an outbreak. Now, even more importantly, although there is no transmission back to humans from dogs or cats or other domestic pets, there have been examples of transmission back to humans from mink, and one report from these white-tailed deer. And in Hong Kong, in January this year, we had an example of a patient with Delta virus in Hong Kong, which was extremely surprising to us because Delta had not been circulating in Hong Kong for many months before that. The person happened to be working in a pet shop. And when we investigated that pet shop, we found hamsters infected with the virus. We traced the chain back to the warehouse, showed the warehouse was infected, and to cut a long story short, we were able to show that the introduction of Delta into Hong Kong in January was through importation of pet hamsters. Now, let me move on to the question of the broader question, the options for prevention and response to these emerging infectious disease outbreaks. So most of these new emerging infectious diseases arise from animals spilling over to humans. So you see the virus may be circulating in the wild animal reservoir. It may spill over into the domestic livestock and then spill over to humans, or maybe directly from wild animals to humans, etc. And we have this human outbreak. So what can we do to prevent it or intervene? Clearly, early diagnosis of cases in humans can help to contain that outbreak in humans. Even better, early detection of that zoonotic spillover before the virus starts transmitting in humans would be even more effective in dampening down such an outbreak. And ideally, if you can understand the drivers that allow viruses to spill over from the wild animal reservoir to either domestic animals or humans, you are even going further upstream in preventing this transmission chain. And I will try to give you examples of especially this one. So what are the options for preparedness and for containment? Now, of course, platform technologies, I mean, the triumph of this COVID-19 outbreak, although you cannot talk of triumphs, but nevertheless, the very rapid development of vaccines has been extremely a credit to science. And as you know, CEPI, the Coalition for Epidemic Preparedness Initiative, who was very involved in the early development of vaccines for COVID-19, are now rolling out what they call the 100-day mission, focused on platform technologies for vaccine development that can be rapidly switched to any new pathogen. So clearly, that is a very important initiative and investment that I think we need to focus on. Clearly, early detection of unusual clusters of infection can interrupt the spread of outbreaks. I mean, Ebola would be a classic example. COVID-19, whether earlier detection would have been able to stop that outbreak is unclear. And then we have what I call control at source. I will explain this a bit more in detail. And then finally, we have surveillance and risk assessment so that preemptive development of countermeasures can be made. And this is, if you like, even going further upstream than it's in conjoint use with the platform technologies. But the idea is that you can risk assess potential pathogens and develop countermeasures even before they spill over. So what do I mean by control at source? I mean, understanding this human-animal interface, understanding the biological drivers of that spillover, and particularly if there have been examples of such zoonotic spillover before, and to reduce the risk of such spillover taking place. Then, of course, at the human level, for example, improving ventilation in public spaces where we know clearly how important poor ventilation has been in promoting transmission of COVID-19. But I will focus on this animal-human interface issue. I don't have to tell this group the factors that drive the emergence of these new, particularly viral infections. There are human activities, includes the wild animal trade, the livestock trade, ecological degradation, deforestation, etc. And therefore, this really highlights the importance of a One Health approach to addressing these problems. Now, in the case of SARS-1 in 2003, after the human outbreak had been contained, the question was where the virus was coming from. And this is where I think Janet mentioned that my colleague Iguan was able to identify the place where the spillover occurred from animals to humans were these wild game animal markets. So these animals such as civet cats and raccoon dogs, etc., a number of these species were infected in these game animal markets. And subsequently, it was shown that it was bats, which is the natural reservoir, but spilling over to these small mammal species, amplifying in these markets, and then spilling over to humans. So the closure of those game animal markets prevented the re-emergence of the virus from this reservoir or intermediate reservoir, even after the human outbreak was contained, because I'm pretty sure, if not for that, SARS would have re-emerged pretty soon after the human outbreak had been contained. Now, of course, with COVID-19, we have had lots of arguments about where it came from. And of course, we know that the natural reservoir are bats, but whether it came from this Huanan seafood market or directly to humans has been unclear. But in the last few weeks, last few months, there have been a couple of papers that came out which certainly, in my mind, clearly address this question and show that this Huanan market really was the epicenter from which the outbreak spread. So, and also there is evidence that this market did have wild game animal, live wild game animals being sold at that market. So very likely it was very similar to the way that the SARS coronavirus 1 emerged. And again, reinforcing the importance of controlling or closing this wild game animal trade. And again, a few months ago, another group has reported testing almost 2,000 wild game animals in this trade and identifying 21 viruses considered at potentially high risk to humans and domestic animals. Again, highlighting the importance of this trade and the importance of controlling this and stopping it if possible. And it's not just human health, but also, of course, this trade is depleting and leading to the extinction of certain species of animals. Now, turning to another example of controlling or containing at source is our interventions in avian influenza. So, as Janet mentioned, these wholesale markets gets distributed into the retail market. And importantly, once one of these zoonotic viruses enters these retail markets, it never leaves, because in the retail market, you have a place where new poultry are coming in and poultry are being removed. So it persists and amplifies in this market setting, and it's from there that it spills over to humans. And also, it then spills back to the farming sector. So we devised interventions to stop this persistence, in initially introducing rest days, where these retail markets are closed for 1 day of the month, then 2 days of the month, and then essentially making sure that the live poultry are sold out, but overnight the market is empty. And what you can see here is an indicator virus that we were using to look at the effectiveness of these interventions. And you can see the effect of these interventions in really reducing virus persistence and circulation in these markets. So even though the markets may be, although they are reduced in number, they still may be kept open because of cultural and other requirements. You can devise interventions that greatly of zoonotic persistence and risk of zoonotic infection in humans. So with this type of approach, from 1997, when we had the first H5N1 outbreak in Hong Kong, we have not had any zoonotic influenza outbreaks in Hong Kong. Although, of course, as you might remember, from 2004 onwards, there were many outbreaks in other parts of Asia. Then we come to the question of, can we risk assess some of these pathogens even before they become transmissible in humans? And after 2009, after the H1N1 pandemic of 2009, the influenza community really worked out a strategy for risk assessing an individual virus that we may find in pigs or wild birds or chicken or whatever it is. And it's based on a number of biological, genetic, and host characteristics. And using this, you can essentially try to assess emergence risk, meaning what is the risk that this virus may emerge to transmit, and the impact risk, meaning the severity of such an event. And one of the important questions, of course, is the ability of the virus to infect the upper respiratory tract. So my colleagues, Michael Chan and John Nichols and others, essentially developed this method of using human tissue that is removed at operation and discarded for various operation procedures, therapeutic procedures, to essentially rescue that and use that for experimental studies. So you can keep these human tissues alive for a number of days and use that to infect infect viruses of interest. So you can see here, for example, this is a human bronchus infected with the H1N1 pandemic virus. You can see very efficient infection. So the brown is the immunostaining for virus antigen, whereas with H5N1, you can see it does not infect the human bronchus, which is why that virus did not acquire, at that time anyway, transmissibility in humans. Now, more recently, of course, when Omicron variants came around, it was important to try to assess and in this case, we are using the lung, assess the replication competence of different variants in the human lung. And when Omicron emerged, we heard about it in November, and we had our first isolates in December. Comparing Omicron with these others, you can see that Omicron is much less efficient at infecting the human lung. And if you look at viral titers in these cultures, it's markedly less than what you see with the wild type and Delta. So by mid-December, we reported to our colleagues internally and to WHO that at least on these experimental models, it suggests that Omicron is less pathogenic in humans, not zero, but clearly less in comparison to the wild type and to Delta. And as you know, thankfully, that turned out to be true. So to summarize, what are the things that we can do for improved pandemic response? I think we really need to better understand virus transmission of respiratory viruses, and associated with that, which interventions work and which don't work. We need surveillance for outbreaks of unusual outbreaks of disease. We now have novel methods of surveillance, such as wastewater sampling. Air sampling also is something that can be looked at. I don't have time to go into all these things. I talked about the importance of surveillance at the animal-human interface and using a One Health approach. And then I talked about prevention at source, understanding the drivers where spillover occurs and then preventing this. Enhancing the development of countermeasures. We talked about the platform technologies, and of course, the importance of equitable deployment of these globally, better communication, and of course, there are many other things that we need to do. And for example, the independent panel has recommended many things, which I think are quite rational. Now, at this last point about better communication, I think you probably have heard that Hong Kong is, after essentially keeping COVID-19 under control for 2 years, now we are having a massive outbreak of Omicron. And the sad thing, and this is what comes to better communication, is Hong Kong, you can see the case numbers here, and New Zealand, you can see the case numbers here in red. So essentially, the Omicron wave hit New Zealand and Hong Kong at the same time. The numbers of cases, the epidemic curve is almost identical, but the big difference is the number of deaths. And the reason for this number of deaths is that Hong Kong, we were unable to convince the elderly, who are the most risk group in our community, to take up the vaccine. At the beginning of this outbreak, only 20% of those 80 years or older had the vaccine. So it just highlights the importance of better public health persuasion, if you like. So I just want to end with this slide, and that is beyond pandemics. So I think this pandemic really highlighted the limits of human hubris. It was René Dubos who, in the 1950s, when people were at that time talking about the conquest of infectious disease with antibiotics and vaccines, he said, at some unpredictable time and in some unforeseeable manner, nature will strike back. Of course, we see nature in full force. And here, this is a more recent review written by Hinchliffe in the UK. And he says, COVID-19 is a symptom, not the cause. And the cause is the planetary dysbiosis, the habitat destruction, the illegal wildlife trade, poor practices in livestock production, and non-sustainable lifestyles. And in regard to non-sustainable lifestyles, I think we really have to realize that in nature, nothing grows forever. And the human species at this moment is risking rupturing the limits of planetary sustainability. And I think there are a number of people, very eminent people, writing on the importance of a change in our way of life and what we regard as economic success. So with that, I will end. I've had the privilege to work with many of these colleagues, and I would like to particularly note the mentorship of Dr. Robert Webster at St. Jude Children's Hospital, who has been a mentor to me and to many of our colleagues. And thank you very much for your attention.
Thank you very much indeed, Dr. Peiris. That was a wonderful talk, covered a huge spread from the beginnings of your work with the flu virus through SARS, and then really giving us important lessons of where we are today. I'll encourage the people on the seminar to enter questions in the Q&A. And I can see Keith Martin up there, and he already has a comment perhaps in the chat. Keith, would you like to ask a question?
Thank you very much, Dr. Rossant. First, Dr. Peiris, on behalf of all of us at CUGH, thank you very much for a brilliant and timely presentation. It fits squarely with what we are doing here. And I really appreciate, Dr. Rossant, your enduring support that the Gairdner Awards have a pride and place within our annual conferences. I wanted to you made a fundamental point, Dr. Peiris, with regard to the intersection between wet markets, pandemic spillover, and the biodiversity crisis. I believe the studies have shown they mapped out wet markets, where they are and what the hotspots are. Can you share with us that these hotspots, these wet markets, need to be perhaps closed in the interest of public health? Do those wet markets, should they be closed in the interest of public health? Thank you.
Yes, thank you for that question. So I just want to distinguish when we use the word wet market, there are wet markets where, for example, things like poultry are sold, which are extremely widespread across parts of Asia and in Africa and other parts of the world. In fact, there are even some in the United States, in New York. And then we have the wild game animal trade. Now, I mean, SARS-1 and SARS-2 clearly, in my mind, came through the wild game animal trade. And I think that is the thing, first and foremost, that needs to be closed, full stop. Now, of course, it's easier said than done because these do have, there's a demand and of course, wherever there's a demand, there's a supply. But nevertheless, I think that's the first and important thing. Now, the wet markets where things like domestic poultry are sold, again, is a risk. But what I showed you is that by understanding the dynamics of transmission of viruses, you can take measures to mitigate that risk. But I completely agree that in the long term, we need to move towards closure of those markets as well. But you do have to, I think, appreciate, first and foremost, cultural predilections, especially in the Chinese community, for eating fresh food because of the way of their cuisine. So they don't like frozen food. And then, of course, a study that done by my public health colleagues looking, asking individuals in mainland China and in Hong Kong whether they would prefer to buy, for example, chicken from the wet market or have frozen. And in those who want to buy meat from the wet market, what was the main reason for them doing it? And the answer in Hong Kong really was a matter of taste. I mean, they believe that, and these are particularly the older generation who are still more traditional. They believe that freshly killed, for example, poultry tasted much better in the Chinese cuisine. But in mainland China, in Guangdong, actually, where this was asked, the first consideration was quality of the food. And in other words, they did not trust what was frozen, whether this was healthy poultry that were frozen or not. So it was a question of trust there. So I think I agree with you. I mean, for example, places like Singapore have effectively, closed the wet market trade. But this needs to be moved forward. But also, in the meantime, there are things you can do to reduce risk. Over.
Well, I guess you also talked about the fact that with SARS-CoV-2, it has gone into other animal species, hamsters and deer and everything else. So there's an ongoing transmission between humans and animals. It's not just in the sort of wild animal game. So it's a broader intersection with the animal community. It brings the whole One Health concept back into highlight.
Yes, in fact, many of us are really worried about, because I think these animal species where the virus has been detected in, that is spilling back from humans back to these animal species, is probably just the tip of the iceberg. Because how widely do we sample these animals, and how globally do we sample these game animals? And the fact that the virus has established a secondary reservoir in some of these species certainly will mean that after some time, the virus may mutate and come back to infect humans. I mean, just to remind you that the 2009 influenza pandemic, the H1N1 pandemic, essentially was the 1918 Spanish flu virus or a descendant of that spilt over into pigs, had been remaining in pigs for that, 90 years, and then come back into humans in 2009. So there is precedent for this, and unfortunately, it is quite a high-risk issue with COVID-19 as well.
So there's a question from the audience, which is, I guess, on the sort of somewhat better side of things, which is that Omicron, your data and the epidemiology data now says is less harmful, but probably more infectious, which is an interesting way, I guess, for the virus to evolve. But the question is, do we have any data on how the BA.2 variant infects the lung, whether it's similar to Omicron? And what is this balance between being more infectious but less harmful? What are the properties that cause that?
Yes, so more recently, we have also looked at BA.2 in comparison to BA.1, and it's very similar. So BA.2 and BA.1 are quite similar, and on the basis of that, we would expect BA.2 to be also less virulent for humans, but I want to emphasize that less doesn't mean more. It doesn't mean no. Yeah. And obviously, when it's more transmissible, as we see in Hong Kong, which is what we are facing, is a BA.2 outbreak. When you have 100 times more cases, even if the virus is 70% less virulent, it means you have many more severe cases and deaths, and that's exactly what we are facing. I think, Janet, your other comment was whether these viruses or COVID-19 will continue to evolve towards less virulence. I have no confidence in that, I'm afraid, because from the virus's point of view, what it is evolving towards is greater transmissibility, and that is what all these variants have been doing sequentially. And now that more and more people globally are immune with vaccination or past infection to escape this immunity. So that is what will drive the virus. So primarily transmissibility and evading immunity. Severity is an accidental byproduct. I mean, it may go either way. So I think we cannot be certain that the next variant will be less severe than Omicron, but you can be sure that it will be able to transmit better, either because it's inherently more transmissible or because it can evade immunity.
Yeah. So everybody, of course, asked the question of, when is the pandemic over? And I think most of us would agree that there is no time at which the pandemic per se is over. And I guess, how do you see the world responding over the next few years to live with this virus, because we have to live with this one, but as you say, be prepared for the next pandemic. So how's the world best equipped to do this?
Yes, so I think complacency is probably the worst thing we can do with COVID-19. Or for that matter, with future pandemics that might threaten us at any time. But I think looking at it optimistically, I think what we see is this, what we call hybrid immunity. So that is people who are vaccinated and then who get breakthrough infections with COVID-19. Invariably, they are mild. But the immune response that is generated in such individuals is extremely broad, meaning the neutralizing antibody response is able to kill not just Omicron, but also Alpha, Beta, Delta, Gamma, Wuhan, everything. And hopefully, I think what that means is that broad immunity will also cover future potential variants. So I think that is giving us a much better protection. I mean, of course, don't misunderstand me. I'm not suggesting anyone who's vaccinated should go out and seek infection. But since that is happening at the population level, I think our overall immunity is building up now. And of course, vaccines are doing a great job. Now, I think the missing link in the vaccine area is the need for mucosal immunity. Now, these vaccines are given by injection. You get good antibodies in the blood and T cells and things like that, which protect us from severe disease. And they're doing a great job with that. But unfortunately, what you inject in your arm does not translate to very effective immunity in your nose and mouth, which is where the virus enters. And that is where, although vaccines do reduce transmission, they are not as effective at reducing transmission as protecting from severe disease. So I think the next generation of vaccines may have to be mucosally administered vaccines, which can be used in combination with the present ones, which may hopefully be able to provide better protection from transmission as well.
Yeah, I think that's an interesting, I've been reading about that as well. The question I would have then, did you think with the mucosal immunity, would it actually reduce, because it would act early on, would it actually prevent some of these kind of breakthrough infections that we were seeing today? Because you'd have that mucosal immunity and you would not be infected by the virus. It would really reduce the initial transmission.
Yes, that would be the expectation, because I mean, the reason why you're having the breakthrough infections is because the mucosal immunity is not so good. So when you get exposed, you get infection, but it does not spread to your lungs and cause severe disease. So when you have that combination, so I mean, the example would be the polio vaccine, the live attenuated polio vaccine compared to the inactivated polio vaccine. Now, of course, we use inactivated because of other issues, but the oral live attenuated polio vaccine was extremely effective in protecting from disease, but also protecting from infection and transmission. And that is because it was essentially giving you a mild infection, an active infection at the site where the virus enters, in the case of polio, the intestinal tract. So I think we need a similar thing. Of course, we have the precedent of the live attenuated influenza vaccines. They do work, not fantastically. So anyway, so it's something we really have to pursue.
Yeah. Well, I would like to thank you again, Dr. Peiris, for a fantastic talk. I think we've all learned a lot. Thank you, Keith, for, again, this partnership between Gairdner and CUGH, and it's been a pleasure to be here. And we intend to be in person at CUGH next year and look forward to it very much indeed. So thank you to everyone who tuned in.